Hey guys, it's Dr. Childs here. We're going to jump right into this advanced T3 dosing and treatment guide. This is for patients who are on the membership because we're going to be going over some more advanced techniques, and I want to jump right in here. So first of all, we really need to establish whether or not you need to be using T3, right? That's one of the main questions that patients want to know. And the reason that I'm even providing this information is because if you don't have this knowledge of how to use this medication, you might back out of using it prematurely because you just don't understand what's happening to your body. So a lot of the things, a lot of the symptoms that you may experience along the way of thyroid treatment they're very nuanced, and so they do require an understanding of what's there. And if you don't have anyone to look to say, is this normal, is this not, then it's going to be really difficult to figure out what you need to be doing. Okay, so that's the whole point of this this discussion here. So do you need T3? Okay, I want to start out by saying pretty much every thyroid patient is probably going to need T3. At least to some degree, okay, with the exception of incredibly sensitive patients, which we're going to talk about a little bit later. And most of the time, you know if you're really sensitive. So, and I'll talk to you about how you want to approach your dosing if you're a sensitive patient. But for the most part, 80 to 90% of you are not going to be a sensitive patient. It's usually maybe even less than 1 in 10, probably closer to 1 in 20 that's a sensitive patient. But most people will need it. So first of all, put it in the back of your head that yes, you're probably going to need it. Second of all, if you have any degree of insulin resistance and leptin resistance, then T3 is probably going to be necessary in some form. Okay, and so, and I want to, on my blog, I don't necessarily elaborate on this, but the chances of you listening to this and you ask yourself, do I have insulin and leptin resistance? The chances are very, very, very high. So whether or not you've tested yourself to know, you probably do. Okay, so that's a very important thing. I would also add here, if you have any sort of weight loss resistance, okay, if you have done exercising, if you've done eating paleo, AIP, ketogenic diet, and the weight has not budged, that is not normal. You have a problem with your metabolics, okay? And so that's probably a manifestation of leptin resistance or low metabolic damage, which we'll get to in a minute. But that's not normal, and T3 is going to probably necessary if you want to fix that problem. Okay, second one is patients with very low temperatures. Usually patients know if they fall into this category. Low temperatures in the body is not normal. It's an indication that you're not producing enough energy, which is a implication, or it's at least implicated in the idea that your metabolism is low as well. The second thing is patients with metabolic damage. These are patients who've done the HCG diet. These are patients who have done yo-yo dieting for decades and decades. That's so, I can't even begin to describe to you how bad that is for your body, and we do not want that. If you're doing that, you need to stop it immediately because it takes a very long time to heal, and it can be very difficult to treat. So the more times you've done dieting in your life, the more times you've done the HCG diet, the fewer calories you're eating on a daily basis, the harder it is going to be for you to lose weight, period. And I don't want to underscore that. I should also make a special little message here that if you have a history of what's the word I'm looking for? Bulimia or anorexia or any sort of eating disorder behavior, even if it was in your teens and your 50s now, those patients are notoriously difficult to treat. And I've worked with some of these patients for 12 months, and maybe 5 pounds are lost. Like I'm not trying to alarm you or scare you if you fall into that category, but just know that it's a very difficult condition to treat. I believe it has something to do with the hypothalamic and axis, but anyway, that's not for this discussion here. So we already talked about the recurrent yo-yo dieting, and then of course if you're a patient and you failed therapy on NDT and or T4 therapy, again, like I said, most people, if you're listening to this, probably do need T3. So the question is, how do you actually start it? This is really the problem. Most of you know you need it, but most of you have no idea how to actually start it. So that's where this comes in handy. So first of all, you need to understand the concept of titration. Titration is the idea that we are going to you have to eliminate from your mind this idea where you need to base your dose off of your labs each and every time. That does not work. It's not a good idea to do that. So just eliminate it. You do need to have some ability to titrate, which means to go up on your dose based off of a set number of days or based off your symptoms, etc. So this is really the way that you're going to want to be dosing your thyroid hormone, any thyroid hormone, by the way, not just T3. But let's talk about T3 specifically. So let's say you are one of those sensitive patients. Now, like I said, you know if you are. These are the patients who they usually have a little more anxiety. They're a little more easily startled. They react to supplements. They react to medications. They react to pretty much anything that you come into contact or that they come into contact with. Okay, so if you are a sensitive patient, you need to take that into account as you increase your T3. I recommend that you start with 5 micrograms of liothyronine or Cytomel, and if you're really sensitive, you may even want to break that in half to 2.5 milligrams. Okay, so T3 comes in 5, 25s, and 50 micrograms tablets. Okay, so that's why we have to go by doses of 5 or 25, as we'll talk about in the normal one. But there's logic behind this. So if you are really sensitive and you're like super sensitive, then start with the 2.5. Okay. Now the idea is for this type of patient, you're going to want to go up by 5 micrograms or 2.5 if you feel very if you just want to be very cautious every 10 to 14 days. Now for you, I would recommend closer to the 14-day mark. Okay. The reason being, there's no rush to get you up to that dose, and I'd much rather you go slowly so that we can get you up by even 5 micrograms in a 30-day period if necessary. So getting to that point would be 2.5 micrograms every 2 weeks, basically. Okay, so put that in your head. While you're doing this, you need to be watching your symptoms very closely. You want to monitor your heart rate, you want to monitor your body temperature, and you want to make sure that nothing feels out of the ordinary. Okay, for sensitive patients, they know how they react, so you need to be mindful of those type of reactions. Now, you may ask, when do you stop? So for a sensitive patient, the most you want to get to is 25 mics. I highly doubt you're going to get there. Realistically, you'll get between the range of 10 to 20 micrograms. Okay, this is if you're a sensitive patient, 10 to 20 micrograms. Now, and you may go, if you're going up by 2.5, you may go 2.5, 5, 7.5, 10, 12.5, 15, 17.5, 20, right? Or some increment like that. Now, you want to go until you get to the 10 to 20 microgram range, and then we're going to recheck your labs. Okay, so you're going to do some titration by yourself for probably a good 1 to 2 months. Okay, and this is how I do it with my patients. So 1 to 2 months on their own before we even check their labs, and that's by design. Okay, so this is intentional. And we'll talk about what to look at for your labs and how to dose yourself. It'll make more sense then. Now, okay, so that's the sensitive patient. You really want to go low and slow. I'm going to talk a little bit about sustained release T3 as it relates to sensitive patients, but you may even want to consider, if you're a sensitive patient, to just start right away with the sustained release T3. Why? Because there's much less risk, it's a little bit easier, and it's a little more tolerated. So let's put it that way. What about if you're a normal patient, though? So normal patients are a little bit easier in that they can start at a higher dose and they can usually titrate a little more rapidly. And so here's what we do. So remember when I said that the T3 comes in 5, 25s, and 50 microgram tablets? It's tablets. So we want to use that to our advantage, and we really want to put a preference on immediate release T3, which is liothyronine and Cytomel. So I'm going to talk about that in a minute, but stay with me here and just realize that we're talking about Cytomel or liothyronine, which is immediate release T3. So the best thing to do is have your doctor prescribe you a 25 microgram tablet. And then what you're going to do is you're going to break that in half each day to take 12.5 micrograms of T3 for 10 days. So this is going to be your loading starting dose, okay? You're going to do 12.5 micrograms for 10 days. Then you're going to up that dose to 25 micrograms for another 10 days. And then you're going to up it to 37.5 for another 10 days. So this is 1 month. So 10 plus 10 plus 10 is 30 days. And from day 1 to day 30, you're going to go from 12.5 micrograms all the way up to 37.5 micrograms. Now you will see here that this is 1.5 tablets. I should have included that. This is a half a tablet. And the 25 micrograms is just 1 tablet, right? Okay, let's put that in there so it's not confusing. Now, this is really how you want to start, and then what you're going to do is once you get up to the 37.5 micrograms, you're going to stay there for a month. So this basically takes care of your first 60 days. And then what we're going to do is the best thing you can do is recheck your labs at that point and kind of see where you are. Now I will tell you, just statistically speaking, getting up to this 37.5 microgram dose, you're going to probably feel a lot better. Okay, and it's not a crazy high dose. It really isn't. It might be too much, and we're going to go over that in a minute, but this is really kind of an ideal dose that you want to get to. And I would say, even if we did nothing else, let's say you had T4, and even if we increased you to 37.5 micrograms per day for a 6-month period, you will still feel so much better. I can't even describe it to you. But getting up there can be difficult, but this is how you do it, okay? So we need to move on, though, because this is the easiest part to tell you, is just how to do it. Now we need to talk about what things might pop up as you're doing it so that you don't get freaked out or scared while you're doing this. Okay, so symptoms to watch out for during your titration. This is critical. The reason is because T3 medication is just not well understood by traditional physicians, so they just don't really know how to guide you. Now, if you went to your doctor and you were like, hey, I want to be put on a blood pressure medication, they could tell you everything I'm telling you about right now, all the nuances to increasing your dose, titrating it, what to watch out for and why about the blood pressure medication. They could not do the same for the T3. And that's why you really need this, to help you understand what's happening to your body. So first of all, since we're doing this titration, it is possible that you may be getting too much, right? Because I can't predict, and I say but the truth is any doctor. No doctor can actually predict how much you are going to need just by looking at your labs. Contrary to whatever it is that you've heard, read, or think, that's not possible. You have to do a trial of, has to be a combination of trial and error and also lab work and some symptoms and such. But it's impossible to determine right away, like, oh, I look at their labs and people will say, well, tell me how much I need. I'm like, well, I can't give that to you. It's impossible. So it is possible along the way that you might be getting too much. And like I said, I've included averages on the low end so that we can prevent most of these things, but it is still possible. So what are those symptoms? So first of all, heart palpitations, but I need to put a caveat here saying they may not be an indication that you're getting too much. It may be that you're getting the T3 too rapidly, but not necessarily an indication that you're getting too much. So we're putting a little asterisk on that one. Another symptom that I hear from a lot of patients is they get this sort of internal jittery sensation. It's like they just feel buzzing with energy is another word that I hear. They don't like it. It doesn't feel good. So watch out for whatever it is that may manifest in your body. Another one is increased anxiety. That's never a good thing. If you're taking a thyroid medication, you're getting anxious, you need to back off on the dose of the medication. That's not normal. It's just not a good thing. The other one is feeling flush, which may or may not be a bad thing necessarily. That could be another case where you're getting a little bit too much too rapidly, but the overall dose is not too much, and we'll talk about that in a minute. So while you're doing the titration, you may say, well, how do I know when to stop? Like, so let's say that you get this internal jittery sensation. What are you then going to do? So let's say you're a quote-unquote normal patient. I'm going to go back here. You start at the 12.5 microgram dose. You take it for 10 days. You do great. You go up to the 25 microgram dose for 10 days. You do great. And then then it's day 20, and you go up to 37.5. And then for the next 3 days, you start to have that internal jittery sensation. Your energy maybe starts a little bit sluggish. So what do? It's really simple, guys. You just go back to the dose that you were feeling good at. This isn't rocket science. Go back to the dose that you felt good at, which would have been the 25, and that doesn't mean we're never going to try to go up. This is just a rough way of doing the titration. So what you would do is you would go to the 25 microgram dose. You would stay there for probably the 30 days instead of going up to the 37.5 and staying there for 30 days. And then what you would do is you would go up by 5. Okay, 5 microgram doses. So you go from 25 to 30 and then 30 to 35. The same way that you would do the titration with the 12.5, but with a smaller dose, right? But the point is, if you experience those things, you don't want to stop the titration and get off all the medication completely. Most of the time, if you just wait 2 or 3 days, the whatever you're feeling is going to go away. You're going to be able to tolerate it, and you can just keep on going through, okay? So keep that in the back of your head. These things may be freaky to you, but they happen all the time to other patients, and they aren't necessarily cause for concern. Now, heart palpitations is a little bit different because that may or may not be something indicating that you need to back off your dose. So the way that I generally do it is I tell my patients, look, if you get heart palpitations, what I want you to do is first of all, you need to back off your dose just to wherever you were previously that you tolerated. So if that was at 12.5, go back to 12.5. If you went from 12.5 to 25, you got heart palpitations, go back to the 12.5 and just stay there for a while. And then the other thing you want to do is another trial of going back up, but just delay the titration out. So instead of going up every 10 days, go up every 20 days. Because it may just be that your heart and your body needs to acclimate to the new dose. Because what has happened is so many of you have been starved of T3 for so long that when we finally give it to you, your body has no idea what to do with it. It just freaks out, and every cell in your body uptakes it, and then you get all these symptoms, okay? Now, in reality, if you just kind of hung in there and stayed there for a couple days, most of the time, those symptoms would completely go away, and then you'll be able to tolerate it just fine. So be intuitive with your dosing, listen to your body, and just when in doubt, back down a little bit. It's not going to hurt you to go back down on your dose, okay? So don't freak out about that. So there are some symptoms that don't necessarily mean you need to stop the titration, but instead you want to slow down, and so those are the ones that I was talking to you about before up there. So heart palpitations would be one of those. Just back down on your dose. If you're feeling a little anxious, back down on your dose. If you're feeling flush, back down on your dose to whatever it is that you tolerated previously. It is worth mentioning that the dose of T3 kind of stacks up and kind of builds up over time and may hit you 2 to 3 months down the line. Okay, so what I mean by that is if you do the titration up to 37.5 micrograms, you stay there for, let's say, 60 days, you may on the 3rd month start feeling a little bit overstimulated as a result of this, even despite making any changes or just staying on the same dose. Now, that probably happens because we're dropping your reverse T3 as we do this, okay? So the thyroid hormone is more effective. It also could be that you're probably losing some weight and therefore your requirement for your dose goes down a little bit. So you need to consider those things as you're doing your dose. But the point is, don't let it freak you out. Just when in doubt, back down on the dose, hang out, and then you can stay there for an extended period of time, and then do another attempt to go back up. There's no rush for this. You don't need to hurry and rush to get up to your dose. Take your time. Do it over 3 to 6 months if necessary. Obviously, I tend to want to push the titration a little bit quicker in my own personal patients. The reason for that is because I want them to feel better, right? But if you don't have the support, if you don't really know what you're doing, it's better to go, low and slow, and there's just no reason to rush. Also, in some patients, you may have to back off for 3 to 6 months and stay at a current dose while you treat your adrenals. The reason for that is, like I said, your body's just it's been deprived of T3 for so long. When it finally gets it, it has no idea what to do with it. And so what you might need to do is, let's say your hypothetical normal dose is 50 micrograms of T3 per day. Like, let's say that's what your body needs. Your body may only allow you to take 25 micrograms per day for 3 to 6 months first, and then you can start to go up a little bit later. So consider that also in your head, that once we get you to a dose, it doesn't mean you're going to stay there forever. It does not work that way. You might need to go up later. You might need to come down later. A lot of different things can change how your body interacts with the thyroid hormone once it's in your body. Okay, so that's the symptoms. The second thing is, what about labs? So this is a very confusing topic for patients, and this is one of the reasons why I never talk about it on the blog, because it's very complex, and this is unlike probably anything that you've ever heard, and this is the way that I do it, and I know that it works. So that's why, and again, it's very complex. It's over the head of most people, but here's what I want to get across. When you're on T3, your labs just aren't that helpful, okay? And it's just the truth. They're just not very helpful. But there are things that you can use to kind of give you a gauge as to where you are in your treatment. And those lab tests, believe it or not, are total T3, reverse T3, and sex hormone binding globulin. So the idea is, when you check your labs, so like let's say you're doing the titration, you start out, let's say you get to the 37.5 micrograms, you do your 12.5, 12.5, then 12.5, you get up to the 37.5 microgram dose, you stay there for 30 days, so you've now been on T3 for 60 days. We would then recheck your labs at that 60-day mark and see where you're at. And so what we would do is then we would then determine how much do we need to go up, or how can we tweak this, what's going on in your body. So that's when you would order the labs. Now the next question is, what do your labs look like? What are you looking for? So pretty much ignore everything else except for the total T3, the reverse T3, and the sex hormone binding globulin. So your total T3, you want it to be just at like the very, very top of the reference range. So most of the time that reference range is something like 30 to 180. It depends on which lab you're using, but let's just say for the sake of this discussion, it's 30 to 180. We want to get you all the way up to the 170s, right up there, 170, 175, something like that. If you go above, if your total T3 goes above that range, you're getting too much T3. Okay. Now that's the point of the T3, the total T3. It helps you to determine, are you getting too much? We can't really determine if you're getting enough necessarily. We can just determine if you're getting too much. And really that's kind of the way that it works with T3. And I'll talk about that a little bit later. The next thing is reverse T3. I only bring this up because it's going to drop, it's going to get low. Don't freak out about it. That's actually okay. That's good. We want it to be low. Okay. But it doesn't necessarily help you. Okay. Now the next thing is your sex hormone binding globulin. Again, your sex hormone binding globulin is there to educate you as to whether or not you're getting too much. You should never have a high sex hormone binding globulin. That's an indication that you're taking too much thyroid hormone. It's not going to be good for your body long term. Now, if you are on oral birth control pills, then that's confounded. We can't really use the sex hormone binding globulin. But if you're not on oral contraceptives or any sort of oral progesterone, then we can use it. And again, it should never be elevated. So here's what I want to bring this all around to. So you may say, well, how come we can only check if we're getting too much T3, and why can't we check to see if we have enough? Now the problem is this: in your body, all of the symptoms that you're experiencing, you may attribute to your thyroid, but the reality is they're not all related to your thyroid. Okay, so if you want to, I'm just going to make this very simple, but break it down. Now, this in each person, this is going to be different, but I want you to consider it like this. So let's say you have fatigue. The subjective symptom is you have low energy. Your energy is a 2 out of 10 on a scale of 1 to 10, right? So very low, 10 being the most and 1 being the you basically can't get out of bed. So you have really low energy. Now you may say, well, if I take thyroid hormone, my energy should go up. And that's true. However, what you have to consider is that maybe your low energy, maybe your thyroid's only contributing 20 or 30% to your total low energy. Maybe the other portion is your adrenal function, which is another 20 to 30%. And then maybe another 20 to 30% of your low energy is due to your weight by itself. So we may optimize your thyroid hormone to maximum, to whatever it is that we can get to. So usually that's about, I say about 80 to 90% optimization with what I'm recommending here. And let's say your energy only gets 30% better. Well, you might think in your head, no, that's just because I need more T3. And that's not necessarily true, because there's other factors causing your fatigue. Okay, and until you treat those factors, you won't know, am I getting too much? Am I getting enough thyroid? Am I not? So that's why we use the labs to tell us if we get too much, but we can't use it to tell us if we necessarily have if we have enough. We just only know if we have too much. Okay, and that's the confusion when it comes to T3, and why I don't really like to at least talk about it on the blog, but we can talk about it here because we can elaborate on these advanced topics. So, like I said, total T3 very top, sex hormone, but you never want it to go over. Sex hormone binding globulin should not be elevated. Now, an optimal range, don't focus on the optimal range, just focus on not getting it too much. Okay, it'll confuse. It's not necessarily that helpful in the grand scheme of things, so long as it's not elevated. Reverse T3, you want it as low as possible. Even if it flags as low, that's okay. Now, what I want you to do is put less attention on the free T3. Why? Because we can inflate that to whatever it is that we want it to be. If I tell you, if I have you take the free T3 at 7 a.m. and I check your blood at 9 a.m., your free T3 is going to be insanely high, and that's because we did that artificially, and it means nothing. So it might be 12 on a scale of 1 to 4 or something like that, and we make it 12, and then your doctor says, wow, your free T3 is super high, you need to go down your dose. No, if we would have checked it 22 hours later, it would have been in the normal range, but that's not helpful to us because we're artificially manipulating it. The total T3 is more of a marker of your long-term T3 stores in your body, which is what we care about more than what is actually available at certain times throughout the day. Okay, so put that in your head. TSH, again, not that helpful, and free T4 and total T4, not helpful at all. Your free T4 might even go down, and that's okay, that's normal. We don't care about that. We care about the amount of total T3 and free T3, but we just care that your body has enough T3 in it. So how do you know when you're getting enough? You really want to base that mostly on your symptoms. So when your dose is in the sweet spot, when it's going to be hard, like it's going to take some trial and error to get there, but when it's accurate, and you're going to have more energy and you're going to start losing weight. Okay, your body temperature is going to go up, your heart rate is going to go up. Those are all good things. You want to get back to normal, so watch out for those things. Now, you can't perseverate on the T3 dosing unless you take care of the other problems, which is why this membership has a lot of different videos and things that you want to talk about. So this is just one leg of many, and this is like how you really want to approach this. So remember that you will know you're on the right track if you start to experience an improvement in these symptoms. Now, I will tell you this though. Some patients have so many things wrong in their body that it's difficult to assess improvement simply because of how much is going wrong. Okay, and in those patients, even 5 to 10% improvement when you're going up on T3 is a good sign. Okay, so put that in the back of your head. Now, that's not going to be most of you. Most of you, when you do it, you're going to feel probably 60 to 70% better within 3 months, and it's going to be like life-changing for you. But for other people, especially those ones if you have like chronic Lyme disease or severe adrenal issues, things like that, it's going to take a little bit longer. But the majority of you will fit into this mold, and it will work out quite well. So here we need to talk about immediate release T3 versus sustained release T3. So what I want you to do, I want you to take this away. So put preference on immediate release T3, which is, in my opinion, superior to sustained release T3 most of the time. Okay, so I want you, and the immediate release T3 means Cytomel or liothyronine. Okay, now the confusing part is sustained release T3 is liothyronine, but it's just bound to methylcellulose, so it reduces the it delays the absorption throughout your body. Okay, so put preference on immediately released T3, which is just from a normal pharmacy. So if you just get liothyronine 25 microgram tablets or Cytomel 25 microgram tablets, that's what you're looking for, not SRT3 25 micrograms. So that's the difference between the two. So, but there are some people who will need it. So how do you know if you need it? I recommend that you start. I start most patients on immediate release T3, which is liothyronine or Cytomel, first, and then if they experience any heart palpitations or rapid heart rate, then I will. And it's an intolerable amount, right? No matter what, if I drop their dose, they still come back. If I play around with it, if we go off of it, it still comes back. If they try it a week later, go back up, it comes back. Like, that's what I'm talking about. So somebody who, no matter what they're doing, no matter what changes they make, their heart palpitations remain. That's the person you want to consider switching to sustained release T3. Okay, and when you do this, there's some nuances you need to understand. So first of all, you really don't want to do it if someone has any sort of gastrointestinal issues. So that means like low stomach acid, small intestinal bacterial overgrowth, any sort of irritable bowel syndrome, any sort of inflammatory bowel disease, any of those things you really want to try and avoid using sustained release T3, because you're going to impair the absorption of the thyroid. And so generally what I say is, this isn't hard and fast, but normally it's like a 1 to 2 ratio. So if you're on 25 micrograms of immediate release T3, you're probably going to need somewhere between 40 to 50 micrograms of sustained release T3 to kind of break even, because you need to consider that most of that's not going to be absorbed, and even less of that's going to be absorbed if you have any of these bowel issues. Okay, so when you switch from, like, let's say you're on 25 micrograms of immediate release T3 and you want to switch to sustained release T3, well, you're going to have to go up on your dose, okay? And that can be confusing for patients, it can be confusing for doctors. The reason is because of the absorption of this whole thing. So, but again, there's really not a good way to figure that out. You kind of just have to go do the same thing with the titration as I told you with the sustained release T3, but do it in variable doses depending on how sensitive you are. So if you're really sensitive, you want to do that titration in 5 microgram increments. If you're not that sensitive, then you're probably going to want to do it in anywhere from 10 to 15 microgram increments. Okay, so every 10 to 14 days or so. So that's how you consider which one to use and why. So average dosing, this is another helpful thing, because like I said, the labs only tell us if we got too much, so it can be difficult to determine, do you actually have enough? So I've given you an idea of what most patients need that I've treated, and I feel pretty confident in these intervals based off of all the patients that I've treated. So somewhere between 25 to 50 micrograms of T3, immediate release T3, I would say 80% of people will fall within that range. So there's an 8 out of 10 chance that you're going to fall within that range. You may need more, but I say that's true, but this is going to be a little bit rare, and increasing beyond that is actually a little bit difficult. So I'll probably make a whole nother video series just on that one topic. But for now, just realize that 25 to 50 micrograms of T3 per day for most patients is going to be probably a life-changing experience for you. Now, what about using NDT and T3 together? I love it. I do it a lot. So depending on the degree of metabolic damage, like if you have a leptin level of 70, you're going to want to be on T3 only. If you have a leptin level of 15 and an insulin level of 10, okay, you can get by with NDT plus T3. Then that'll probably be better for you. So I have a lot of patients on the 1 to 2 grain range of NDT, in addition to the 25 to 50 micrograms of immediate release or sustained release T3. So that's a pretty good amount to be combined with, and it's not too much. So don't worry about that too much if that's the case. So the last thing is, whenever we're doing this, you want to start with NDT dosing first, and then you want to switch to T3 later on. So what we do is, and again, that'll be in another video series on how to do the NDT, but generally what I say is, don't start with the T3, start with the NDT first, and then once you determine that, because what's going to happen is you'll start with the NDT and you'll start to feel better. A little bit. You may not feel all the way better, but you'll feel a little bit better. So you might get up to the 1 grain dose and feel pretty good, feel 20% better, get up to the 2 grain dose and feel 40% better. And then at that point, if you're at 2 grains and you're still only 50 to 60% better, that's when you want to try and add the T3 on top of the NDT, because that's going to drive you up to the 80-90% better range. And that's exactly what we want. So I say that only to imply that I want you to start with the NDT dosing first and then switch to the T3. Okay? So anyway, that is all I have. I know that's actually a pretty complex topic. So if you have any questions, let me know. Feel free to let me know, and we can kind of go over those, because I'll be refining these and adding to these as we go, because there's a lot of information. It's really hard to get that amount of information across, but we're going to do our best. So let me know if you have any questions about that. Otherwise, I hope you guys found this very helpful.